Good evening, Endometriosis Summit crowd, and welcome to this fantastic event on endometriosis and PCOS. It is PCOS Awareness Month, which is why we wanted to discuss this, but I bet a lot of people out there in our crowd have been either misdiagnosed with PCOS instead of being diagnosed with endometriosis, or have been told they can't have endometriosis because they have PCOS, or they can't have PCOS because they have endometriosis. So we wanted to talk about both of them. And we are hosting a virtual fertility weekend on October 24th and 25th. So we will have a little bit of a fertility slant tonight, but we will try to get everything in that we can get in, because that's just how Dr. Vidali and I do it. If for those of you joining us on Zoom, you can ask your questions in the Q&A. Again, we will try to get to them. Those of the questions that we don't get to, maybe we'll have Dr. Vidali answer them on his Insta stories tomorrow. All right, please welcome this evening Dr. Rashida Daisley. She is from Barbados. Dr. Daisley, can you tell everybody a little bit about yourself?
Okay, sure. So first of all, I'll just start by saying I know that I have an accent compared to everybody. So if I'm talking too fast or you don't understand me, please let me know so I can just correct myself. So as you said, I am from Barbados and it is very, very hot here, first of all. I'm not sure what the temperature is like where you guys are. So I am a medical doctor, I'm a general practitioner, but I also am a public health physician. So I did complete my Master of International Public Health in Birmingham, UK. On returning to Barbados, I became the clinical director at one of Barbados's oldest NGOs, the Barbados Family Planning Association. And I also work very closely, I'm the vice president of the Barbados Association of Endometriosis and Polycystic Ovarian Syndrome, which is another nonprofit organization that advocates for women not only with these conditions, but other mental health disorders.
So we love your organization. We follow them on Instagram. We want to tell everybody what the Instagram is.
Sure, so the Instagram for Babe is Endo and PCOS BB.
Yes, and they have their own education and it's really fantastic. So please go ahead and give them a follow. Also, please welcome this evening, Alexis Alchular. Please tell everybody a little bit about yourself.
Hi, everyone. Well, thanks so much for having me tonight, Sallie. It's just funny how things just seem to come full circle, and here we are all sitting together. Dr. Vidali, I was lucky enough to find him after hopping around from 2 other clinics in New York City and several doctors, and was unfortunately misdiagnosed or undiagnosed, or I should say diagnosed with unexplained infertility over the course of 3 years. Unfortunately, had to go through 5 rounds of IVF just to get to the point where I was finally getting some answers. And it turns out that I was suffering from silent endometriosis, PCOS, and insulin resistance, which were really the core issue behind our fertility struggle. So luckily, round 5 with Dr. Vidali, I had my son, but it took us a really long time to get there.
So we just want to point out to everybody, getting to that core issue, that's what our reproductive immunology day is all about. And Alexis will talks a little bit about insulin resistance, and we can talk about how that impacts endometriosis. Also, I should, while he's sitting there in the OR, like, you know, we had to run out, and please welcome Dr. Andrea Vidali. Dr. Vidali is my partner in crime for the Endometriosis Summit. He is both a endometriosis excision specialist and a reproductive immunologist. Welcome, Dr. Vidali.
Good evening, everybody. Hi.
Yeah, you can see he's still in the OR. Nobody get PTSD over everything that's going on behind.
Oh, sorry, guys. It was good light today here. It was good light.
Yeah. So, Dr. Daisley, do you want to tell us a little bit about what PCOS is?
Sure. So PCOS is an acronym. It stands for Polycystic Ovarian, or some persons say Polycystic Ovary Syndrome. And it's a very complex disorder. It's both metabolic as well as reproductive, meaning that it has reproductive implications in terms of fertility. But I also heard you mention insulin resistance, sorry. So there is an aspect of that as well. So it's one of the most common reproductive disorders, affecting up to 10% of women of reproductive age. Of course, that varies across ethnicities as well as age as well. Some of the most common symptoms associated with polycystic ovarian syndrome or infertility, as we would have mentioned. Ladies also have signs of hyperandrogenism because the levels of the male hormones are a bit higher than for persons without PCOS. So they would have symptoms like abnormal hair growth. Some they have upper lip hair, some on the chest. They do have abnormalities with the menstrual cycle. So majority of ladies would actually present with actually not having a period for a prolonged period of time. They may come in and say, oh, I think I'm pregnant, but is that when we do the pregnancy test is negative. But some ladies can actually present with increased frequency of their periods as well as longer menstrual cycles as well.
And what are Alexis, you had interesting symptoms of sort of PCOS. What were your symptoms? And then Dr. Daisley, when she's done, I know that you have some experience with this as well. I'd love to hear what your symptoms were. Because like endometriosis, tons of people have tons of different symptoms. So Dr. Vidali, by the way, now he's in the OR. So
okay.
He did just duck out. Yeah. Okay, just so everybody knows. But Alexis, what were some of you had very interesting symptoms of polycystic ovarian syndrome that everybody missed. What were some of your symptoms?
Right, so I would say the two leading symptoms that I had that myself as the patient didn't really think anything of was that I would create a lot of follicles. So every time I would do an IVF cycle, I would produce anywhere from 20 to 30 follicles, which for the age of 33 to 34, I guess, was on the higher end. My other symptom that I later found out was a sign of PCOS was my really high AMH. I think at one point it was like almost a 9. So many doctors had told me, you know what, oh, the higher the AMH, the better. You've got like your fertility is gold, it's great. And then the second that I started to kind of like unravel the pieces with Dr. Vidali and Dr. Braverman, I actually learned that that was actually a sign of PCOS, this very, very high AMH level. And so then we kind of started to peel back the layers and learn a little bit more. I also had persistent, like unexplained weight gain, a missing cycle, but things that I never really had pieced together, but I did have those symptoms in hindsight when I look back.
Excellent. And Dr. Daisley, what are some of the symptoms that somebody experiences with PCOS?
Okay, so some of the most common symptoms, as I said, first of all, would be the menstrual disorders. They might either have a missing cycle, as Alexis would have said. Sometimes they might have increased frequency. She also mentioned issues with weight. So there is a larger subset of ladies, about 80% of ladies with PCOS, who would notice that they gain weight very easily or have difficulty losing weight. But there's actually a smaller subset, which we call lean PCOS. Those ladies don't really have any issues with their weight. Additionally, as I said, they might have abnormal hair growth, upper lip, chin. Some ladies also note this excessive fatigue as well. There may be signs of insulin resistance like acanthosis nigricans, which is the darkening at the sides of the cheek or the neck or the underarms and so on. Yeah.
And Dr. Vidali, while you're here, what's the interplay between endometriosis and PCOS, both for the pain patient and for the fertility patient? He's muted. Unmute yourself. Unmute.
Okay, can you hear me now?
I can hear you now.
Okay, fantastic. Sorry. I would like to mention a couple of things. One is that, like we just heard from the other speakers, is that PCOS is a multifaceted disease. So, you know, you have to get away from stereotypes where, oh, if a person to have PCOS has to be overweight or under, you know, you can have people who are overweight, you have people who are normal weight, you get people who have underweight. you know, like that doesn't mean that they don't have endometriosis. They don't fit if you can't fit them in a certain box. Okay, I think that's very, very important. And the second thing that I would like to add is that endometriosis is really a metabolic condition that evolves throughout the life of a person. So if a person may have very polycystic ovaries and a high AMH when she's very young, but when that person becomes older, the ovaries may not look polycystic, the AMH may not be high, but that person still has PCOS, still has the metabolic problem. So all these things have to be kept into consideration. I'd like to say this is very important because doctors forget these factors. When it comes to the connection with endometriosis, I think is that these two conditions are both inflammatory conditions, and they can easily coexist, okay? One of the issues has been that because of the mythology that endometriosis comes from reverse menstruation, a lot of doctors that are who do not understand endometriosis, they will say, well, if you have PCOS and you don't have your periods, then you cannot have endometriosis. You know, this is the insanity, right? And because of this stereotype based on wrong knowledge, there's many persons who have a combination of PCOS and also have endometriosis who have to live in pain for a very long time because of this problem, okay? The second stereotype that I just mentioned, that of the person who's not normal weight, who's like above average weight. The whole idea is that, oh, because you have PCOS and you're overweight, endometriosis is a thin person disease. That's the other myth, right? And we know that plenty of persons who are not thin have endometriosis. So, you know, we see here the interplay of sort of like beliefs that are not scientifically based, that doctors use sometimes to diagnose patients or to misdiagnose patients, and things get missed that way. So I think if there's one important takeaway here for doctors is that you have to listen to your patients and dig deep. Do not accept, you know, what looks on the surface. And I think for the patient is do not accept dismissive responses from your doctors.
Right.
And Alexis.
Right. Absolutely. Absolutely. That's one of the things that we try to teach you. That's why we do these, is because we want to educate you to be able to know what to look for and what to talk to your doctor about. Dr. Daisley, what are some of the, I hate to use such a word as interventions for PCOS? Is it really just about diet? Because sometimes I think that that's a myth.
Yeah. So first of all, I just want to really reiterate the points that Dr. Vidali would have just made in terms of the patients are not accepting this dismissive diagnoses. As he said, they can coexist, but even within the separate diagnosis, particularly with PCOS, persons sometimes going to their doctor and they're just told lose weight and sent away, as you would have just alluded to in terms of diet and weight loss. So sometimes that can be very, very dismissive for the patient, and it really do has a large mental toll on them. So in terms of the interventions, the main thing that we first have to deal with is fertility. Obviously, it's a cause of infertility, but we really need to know what are the patient's reproductive goals, particularly within the next few years. If the patient isn't looking to have a child within the next year or so, often the physicians may offer the patient the birth control pill to kind of ensure that they have a bleed. One of the things with PCOS is that during those periods where they're not having a period, basically, their lining, the endometrium, can continue to build up, and that may lead to something called endometrial hyperplasia. So to avoid that, we try to place patients on the birth control pill to ensure that they have a bleed and prevent that building up. Another intervention that's often used is metformin. So metformin is actually a diabetic drug. It's an insulin sensitizer. So I don't think we really fully touched on insulin and its role in PCOS as yet, but in the majority of cases, it does play a big role. So insulin is a hormone that affects blood sugar control. It basically is that lock that takes the sugar into the cell. What happens in PCOS is that they're insulin resistant. So the insulin isn't working as well as it should. Sometimes you can imagine it, you know, sometimes you're coming home late and you're trying to get that key in the door, you can't get it open. Similar to that. So what happens is, as a result, as the insulin isn't working as it should, you have higher levels of insulin. So you need a lot more insulin to do a particular job. And those elevated levels of insulin can then affect the male hormones and the reproductive hormones. So the metformin helps to sensitize the insulin, lower those insulin levels, and can therefore help to ensure that the cycle becomes regular. Right. Go ahead, sorry.
Go ahead. Keep going, you're doing it.
Right. So there's one other supplement / medication that I like to touch on. Is called Inositol, Inositol. It's a vitamin kind of, it's a form of vitamin B8, some persons would say, and it really does help in PCOS. One of the issues with the metformin is that ladies normally say that it causes gastrointestinal upset. So a lot of the time they might have diarrhea or sometimes nausea or vomiting, particularly in the early stages. So with my patients, I like to tell them to start at nighttime. So if they do have diarrhea, they're close to home until the body becomes acclimatized. But with inositol, you do have similar outcomes in terms of fertility and regulating the menstrual hormones without those gastrointestinal symptoms.
Yeah, I like the use of inositol. Oftentimes comes with diet. Alexis, when you found out you had a little bit of insulin resistance, the doctor, first of all, you could tell everybody the doctor you were working with, because we like to pay tribute to him. But second of all, did you try to intervene in your own life a little bit with some diet?
So I did. It actually wasn't until I was under Dr. Braverman and Dr. Vidali's care when they had suggested, you know, as I prepared for that 5th IVF cycle, to do my best to eliminate gluten and dairy and those inflammatory foods, but also I introduced my inositol and metformin and a couple of other things. But really, those were the main things that I did. I actually completely stopped exercise. I was a little bit of an exercise junkie before. So as I was making all these changes, I just took it really easy. I went for long walks, but so I made those diet changes and then took it really easy in terms of fitness.
Were you an exercise junkie because you had that, not only because you enjoyed it, but because you had this propensity to gain weight? Because my experience with PCOS, although I didn't get my numbers were always fine my whole life until I was perimenopausal, and then it became rather blatant. But I was like the person who worked out all day, 2 hours a day, sometimes twice a day. And I was like so crazy I love how Dr. Daisley and Alexis are nodding. I worked out all day. I was like on a nut job about food, and I had this subclinical process going on, and and it wasn't until like in perimenopause, you'll all learn, because you guys are younger than me, that if you eat a carb in perimenopause, you sweat to death. So it wasn't until that was upon me that I needed the inositol, that I got a little bit of metabolic syndrome, and then I added in the metformin, then I finally figured, then my PCOS blatantly showed. Right. And we all know I have endometriosis, but I see that a ton. In fact, I had a patient today and somebody told her, a nutritionist no less, her endometriosis pain will go away if she could just lose weight. And I was like, did you just roll your eyes into the, please, because it's not so simple. So you saw it in your own life, but did you have that experience for years on end before you knew what was going on?
So I did. I actually didn't really start exercising or caring about fitness and what I was putting into my body until maybe 8 years ago. I'm about to be 37. So I guess that kind of on the later side. So and then I feel like I was making up for lost time, and I was trying to redeem myself from all those years where I was just eating pasta and ice cream and just not moving my body at all. But then I think now when I look back, I was definitely a yo-yoer in terms of weight. And when I had reached the point where I was under Dr. Vidali and Braverman's care, I had gotten back up to the highest weight that I had been, but I was still exercising 5 days a week, and I was eating a very healthy plant-based diet and still seeing the scale go up and up and up. And then they put me on metformin. I made these changes, and I actually ended up losing 30 pounds, like over, I don't know, maybe like not 9 months or a year, but no exercise, no fitness whatsoever. But it was really just, clearly it was a sign that my body was really just off and it needed some help.
Yeah, I actually wanted to add there as well, because I don't think I've said it so far for the discussion, but I also have PCOS myself, and it was not in my head so intently because I was just like that, just this exercise junkie going at it. I was kind of obsessive about my diet as well. But what I learned afterwards is that the excessive exercise can actually be negative for ladies with PCOS, particularly like using high intensity interval training too often. I sometimes exercise twice a day, but these forms, it is a form of stress really, and it causes our cortisol levels to increase, and that plays right back into that insulin resistance and can worsen our symptoms.
Hey, COVID and cortisol levels. So now let's talk about maybe how that impacts, like, I know you're in Barbados. For those of us in the States, it's like this all day long. Does regular stress impact the cortisol levels and the insulin levels?
So regular, about chronic stress, not like your random, like one day you're stressed and you're back, but some persons are under chronic stress, and that can definitely raise cortisol levels. It also raises prolactin levels as well, and that can all play back into the disorder of the menstrual hormone. The cortisol itself, because that plays into insulin, because it feeds back into that whole insulin cycle, can also have other metabolic implications, particularly around times of stress. I don't know if we would realize that we crave lots of like sugary foods, because the cortisol causes us to crave these high energy foods, and once again can worsen PCOS by increasing fat and so on.
So I see, I know you talked about it, I call them skinny fat, but the skinny PCOS person, that rail thin person who's like, I want a donut 4 times a day and I never gain any weight. And we all, I'm not gonna lie, we all hate that person. But I think you should also, I'm sorry, but what you should realize is that's also a metabolic side to PCOS, right? Because it's insulin in a different way. And so you don't, that's a common fallacy. Like, you have to be fat to have PCOS. No, you don't. And so Alexis told us a little bit about her story. So I mostly, as a physical therapist, see the people that just struggle all the time with all the issues. But in terms of fertility, I think it's very important to realize something happens there with the eggs. Alexis, can you share with everybody how, so Alexis was a patient of Dr. Braverman. Dr. Braverman has passed, so no one can be his patient. But I want you to share a little bit of the questions that he asked you that led to why he thought you had PCOS, because it was like a ding, ding, ding moment when I heard you say it.
Yeah, absolutely. So it was just, I would say maybe like an 8-minute phone call that we had. And again, this was after 4 rounds of IVF. So I was like, I just don't trust anyone. Like he can't, there's nothing he's going to tell me that's going to make me, feel otherwise. But he did ask me if I could remember what my AMH level was the last time it was checked. And I told him it was in the 8 to 9 range. And he asked me how many follicles I typically produce with each IVF cycle. And I told him anywhere from 18 to 30. And he said, okay. I think he asked about my cycle, if I had a regular cycle. I said, no. And he said, okay, I have a strong inkling that you have endometriosis, PCOS, and insulin resistance. Why don't we have you come in and we'll do an ultrasound to check the blood flow to your ovaries and all of that. So next thing you know, I was in the office getting this test done. He found restricted blood flow. 2 weeks later, I was having a laparoscopic surgery with Dr. Vidali, where he did discover endometriosis, and not so much over in my reproductive organs, but on my colon, rectum, behind my cervix. And I had no signs. I had never had heavy periods, pain, anything like that. So that's kind of all how it got pieced together, if that answers your question. But it really started with those 3 main questions.
So Dr. Vidali is missing. I just want to add that, and I see this, especially the teen with endometriosis, with PCOS never thinks about their fertility. But when you have endometriosis, your eggs are naturally aging faster than a normal person. So if you go at like 30 and I'm probably not going to have a baby till 38, and you have this like insane animal, like, oh, you're fine, you don't need to worry about it. If you're experiencing things like this sort of weight gain you can't do anything about, you're a little sensitive to sugar, maybe you have a little facial hair, you have some fatigue, you have, that just because your AMH is high doesn't mean it's a natural measurement of what's actually there, because the AMH is falsely elevated from the PCOS. And so we still haven't taken care of protecting your fertility if you have both endometriosis and PCOS. So we have a question from the crowd. I think it's a good time to ask this. Dr. Daisley, do you recommend a specific kind of diet for PCOS? And my second part of that question is, does diet fix it all? Because I think so many people with PCOS are backed up against a wall to have a certain kind of diet.
So no, obviously diet doesn't fix it all, but in my opinion, it does play a crucial part in managing it, because PCOS management is not only about fertility, but we also have to look at prevention of non-communicable diseases like diabetes and hypertension as well. In terms of the specific diet, Alexis would have mentioned part of it in terms of gluten-free and staying away from those pro-inflammatory foods. Additionally, she mentioned something here about low carb. So low carb, yes, but I think about the quality of the carbohydrates is more important. So we want to make sure that we're using more complex carbs that digest a lot slowly and doesn't cause that quick spike in the insulin levels that can sometimes lead to what I call the hangry attacks. Those slower digesting, low glycemic foods release the carbs a lot slower and produces a steady state of the insulin that really does help in terms of PCOS symptoms.
So Alexis, did you notice when you went on the medicine, like, and the Inositol, like, I was always the person that, like, people would be like, have a snack, because I'm a very strong personality to begin with. So, that up and down crash, I just thought I was a moody, bitchy person. I didn't realize that I had this subclinical experience going on with my hormones and my metabolic system. Did both of you notice that when you finally were able to get treatment?
Yes, definitely.
Yes, absolutely.
Yeah.
I feel like I'm part, yeah. And then I also, if I go somewhere, which it's COVID, so this doesn't happen. But if I were to go somewhere for dinner and they put sugar in the food and I don't know, it's amazing how I turn into that bad person again. Because I still remain, I'm menopausal, so I remained really sensitive. And so if you're like that person that's hangry, like you just mentioned, maybe PCOS is something you could think about. So we have a question, and Dr. Daisley, can you have just PCOS, or does it have to come with endometriosis?
Oh, definitely. You can have just PCOS. Actually, it's more common. Persons with PCOS and endometriosis, that's definitely not the predominant or majority here. So it's more common to have PCOS. As I said, the general statistic is 1 in 10 ladies of reproductive age.
Yeah. What is the connection between PCOS and diabetes and unmanaged PCOS as the person ages and diabetes? Is there research on that?
Yeah, so definitely ladies with PCOS do have a higher risk of developing diabetes, again, as a result of the insulin resistance. So we really do have to make sure that we're monitoring it. I think particularly in the early stages of insulin resistance, the test that we use to really diagnose that is of great importance. Sometimes as physicians, we might really just do our HbA1c, our fasting glucose tolerance test, our fasting our blood sugar, our glucose tolerance test. By the time that gives us information in terms of impaired glucose tolerance, it might be too far gone, basically. In Barbados, I don't think that we have the test really that would test for early signs of insulin resistance. I'm not sure what test Alexis would have had if she would have had just the insulin test, or maybe just the blood sugar test, or if she would have had like a clamp test or insulin to glucose ratio.
You know, that's an actual really good question. I know Dr. Braverman was a genius in drawing conclusions. Can you share with us some of the testing that you had to be diagnosed, Alexis?
Yeah, I mean, I have basically, if this helps sum it up, I have a 13-page report that he had and his research team had put together following my initial workup, which was, you know, a very in-depth immune panel. So testing, I guess, I'm going to butcher it, but that
yeah.
times 60 things, or maybe even 200 other things. I have a laundry list, and I actually go back and reference that document quite a bit when I'm connecting with friends and people in this community who haven't gotten answers, who are trying to still figure out, you know, what their diagnosis is and why they can't find someone to help them figure it all out. So I reference that quite a bit, but it was some very extensive testing, which I continue to get throughout my IVF cycle and then throughout early pregnancy. So it was very in-depth, but I'm happy to, if anyone has specific questions, I could probably pull together a couple of examples.
Okay. So in the fertility patient, PCOS affects a little bit differently, but also that endometrial hyperplasia that Dr. Daisley was describing actually becomes an inflammatory insult to implantation, right? Yeah. So oftentimes if you have been failing have a lot of implantation failures, we need to look at what else is going on, which is the report that Alexis is discussing. We have an interesting question. Dr. Daisley, if somebody is having a hysterectomy for adenomyosis, so not for endometriosis, because we know it doesn't do anything for endometriosis, you have to excise the lesion of endometriosis. Does a hysterectomy help with the PCOS?
Well, I'm not sure how to answer that question in terms of the symptoms in terms of metabolic.
Right. Well, so she's basically gonna say it. It's a question from our crowd. And does removing the uterus help any of the metabolic symptoms that come with PCOS? Just answer honestly.
No, because just removing the uterus would affect the play itself on the uterus itself, but the hormones, the metabolic disturbance will still remain.
Right. So then what I find is that when you remove the uterus, if somebody has a tendency to have a little bit of metabolic syndrome, it's going to get a whole lot worse, a whole lot quicker. So that's why, even though adenomyosis may be a reason to remove the uterus, we want to consider the patient as a whole. So does taking out the ovaries in someone with PCOS actually do anything for them? Because we see that all the time.
So actually removing the ovaries themselves, it can help with the symptoms. Obviously, you're going to premature menopause, and that's going to be a whole new slew of issues there. But sometimes in PCOS, it's kind of like a chicken and the egg in terms of the same insulin resistance and obesity causing PCOS versus PCOS causing obesity. So particularly for those ladies who are obese, there's still going to be that metabolic disturbance that we really do have to play a close role on. But in terms of the reproductive symptoms, removing the ovaries would make things better from that regard. But once again, you now are in premature menopause and you have a whole new slew of issues that you would have to manage.
Right. So my clinical experience is that patients of mine who already were a little heavier once they've removed the ovaries become even more insulin resistant and
Yeah.
more happy because of the interplay between the menopausal hormones and
Yeah.
everything else.
Yeah.
Have either of you, oh, I wonder if it was part of your program, Alexis, have either of you used Knack or NAC for PCOS?
We
No.
haven't, no.
No. So my experience, we have a question from a pharmacist. We have a very sophisticated crowd tonight. And so one of the questions talks about Knack, which I believe is an anti-inflammatory, somewhat similar to using low-dose naltrexone. It's not going, I'm just going to answer to the crowd, it's not going to reduce the endometrioma size. Endometriomas need to be treated by a specialist that knows how to deal with the endometrioma. You're not going to shrink them with anything herbal or medication. What it may do is reduce the inflammation around the endometrioma. Our position in the Endometriosis Summit is typically to have that excised by a specialist, or if you're trying to get pregnant, to discuss whether you should get out eggs before you have it excised, because implantation is going to increase, the ability to implant is going to increase once the endometriosis and endometrioma is there. By the way, if somebody has an endometrioma, I guarantee there's endometriosis elsewhere in their pelvis. There's just no way that you're going to have ovarian endometrioma and not have endometriosis in many other areas. So that's also why I don't just, you know, let's try these things. So I'm curious, Alexis was a little off topic, but you had silent endometriosis. Do you want to share a little bit about, we're going to have a whole discussion about silent endometriosis with Receptiva when they come on. I believe they're coming October 20th, but do you want to share a little bit about silent endometriosis? I really missed the big guy for this, but he had to go into the OR, he had an emergency with a patient.
Yeah, I mean, I would say mine was completely silent simply because I had shown no symptoms of, you know, typical symptoms of endometriosis. I never had very heavy periods. I never had painful periods. I never had many of the stereotypical symptoms that you see with endometriosis. So when I came out of surgery, well, first I was hesitant to go into surgery because I thought, oh, going into the surgery, I bet you I don't have endometriosis. And then Dr. Vidali wakes me up to tell me that I did have endometriosis, not severe, but enough to cause some damage to my eggs. So yeah, it was there and I had no idea. And he also explained, and Dr. Braverman had explained, that every time I was doing an IVF cycle, it could have kind of exacerbated whatever was already in there, because I was, you know, just adding more and more hormones every single time over a very, I would say, short period of time. Over maybe a year and a half, I had done those four to five cycles. So, but yeah, silent because I had no idea until I came out of surgery. Had no sign.
Somebody is curious how long your surgery was, if you don't mind sharing.
I would say under 2 hours, definitely under 2 hours.
So first of all, the length of surgery does not have anything to do with the amount of endometriosis, especially for those using the robot. I know my first surgery was 6.5 hours long. That's a lot of years ago. They don't do that anymore because they have the robot and they can work a lot quicker. But one of the things we talk about with silent endometriosis, and you can, there's some great articles, all published by Dr. Braverman, by the way, on silent endometriosis and gluten intolerance. And so part of the workup when looking for silent endometriosis oftentimes includes looking for this marker of gluten intolerance. And you can predict the presence of silent endometriosis for that. Also, for somebody like me, who waited 23 years for a diagnosis of endometriosis, I was gluten-free like by the time I was 20. So, and I wasn't diagnosed till I was 35. So I can say that those of you that are modulating your pain with diet and are still maybe having some trouble, it could be the presence of silent endometriosis. The other thing is there are all sorts of markers in the uterine lining, and we will have a separate live on that directly. But evaluating for those markers can be a good sign of whether or not you have endometriosis that affects your fertility, not necessarily like I've been going to doctors for 10 years and no one's been able to help me. Yeah, that's a whole other story. That's called not so silent endometriosis. That's called very loud endometriosis that doctors are, and that is usually our specialty. But tonight we're changing it up because we're talking a little bit about PCOS for PCOS Awareness Month. We have a question about acupuncture and PCOS. Have you each tried acupuncture having PCOS? And also, what is your opinion on acupuncture and PCOS?
I haven't tried it personally for PCOS, but I do think that there's a role for these therapies are non-conventional therapies in the management of PCOS, mainly for like the symptoms, the pain, but I'm not sure in terms of like the core metabolic or hormonal abnormalities.
I did a lot of acupuncture. Yeah, go ahead, Alexis.
Oh, I was going to say I did acupuncture before, during, after every single IVF and fertility treatment that I had done. You know, how much of it played a role in my success is hard to say because I had been doing it the entire time. But I believe that if anything, it brought me a little bit of peace of mind and relaxation, which is equally as beneficial throughout, you know, all of this. So
I find with the acupuncture, and we're going to have an acupuncturist talk on the Sunday of Virtual Fertility Weekend, but I find that they're really good sleuths. So a lot of acupuncturists right away will say, hey, are you on the Inositol? Are you, you know, they will look for like your nerves are really inflamed. Also a good physical therapist may look for this too. Are you on a low sugar diet because you're reacting to this inflammation? It's not that they're able to like fix the whole problem, but they provide a piece that can give you like take home right now, how do I do this and where do I go from here? And I think that is part of the role of the acupuncturist, and that could be really good. So what we have a lot, I can't believe how many questions that we have. So many of them we need Dr. Vidali for because they're about like specific transfer related things, which usually I don't ask, but maybe I can get him to answer them on his Insta stories tomorrow. Oh, we have an excellent question from the crowd. Dr. Daisley, what is the relationship between a non-alcoholic fatty liver and PCOS?
Yeah, so I was actually going to wonder if we want to touch on that. So back once again to the insulin resistance. So insulin normally would take the sugar and either take it to either your skeletal muscle, which helps us to do whatever exercises we have to do. If you're not using it for that, it can either be stored as fat or it can go and be stored in the liver, and where it's also stored as fat. So what happens is because you're insulin resistant and there's so much sugar there that's not really being metabolized, it goes into the liver where it causes non-alcoholic fatty liver disease. And that can really have some implications if it's left untreated for a prolonged period of time. It can increase your risk of liver failure. Sometimes it's often diagnosed just incidentally when persons just do their LFTs and notice that they're mildly elevated, not so much in a range that tells us like maybe some other biliary issue, but it's just mildly elevated and no other cause. And it really can either lead to also to like liver cancer later down in life. But again, that is one condition that can be managed or reversed with dietary changes as well.
Excellent. What do you do to help people that have that connection between the fatty liver and the PCOS?
So often nutritional counseling, definitely. And I myself like to refer my patients onto a nutritionist so that they can get like quality nutritional counseling as well. Because I find sometimes as doctors, we're not traditionally trained in nutrition. So I do like to refer them to the nutritionist. But once again, those low carb, gluten-free, anti-inflammatory diets do tend after a while to help manage the fatty deposits within the liver.
So somebody is asking, what is the herb? What I love how I'm like not able. So this is the Inositol. It happens to be the brand that I take. I tried for years to do it just with the herb, and I have to tell you, going to the Metformin completely changed my life. Those of you that have followed for a long time, and this is not the only reason why, but I also lost about 40 pounds in the past year. But then COVID came, and I just don't think that COVID's not good for me. Who puts pretzels in the house all the time? Right? So I had that. I'm sure you two are laughing, but I had that my whole life. Like I would work in a big clinic, and we were, most physical therapists, lots of women, and we'd be like, everybody would be sitting there with their raw carrots and their pretzels and their skinny Sarrel, and I'd be like, if I eat that carrot, I'll be 500 pounds. Are there just foods that we think that are healthy that are maybe not for people with PCOS?
Yes, I would say, but I'm from the Caribbean, and there's one particular food that I would talk about, which is mangoes. Oh dear, mangoes. We have like a mango season where they're
it's like my favorite.
Yes.
I'm addicted to dried mangoes.
Yes.
Oh.
So everybody thinks, fruits are good, eat lots of fruits, but mangoes have such a high sugar content, and we really should stay away from them with PCOS.
So is it something you can have so it's funny because people I'll be like, if I eat that mango, then I can't have my, I get like one piece of chocolate a week, but it's like mango or chocolate. But that's what it really comes down to, I think, when you look at that glycemic index.
Yeah.
So are there other, Alexis, what else do you try to avoid that all your friends probably think are healthy, but you're like, this is death for me?
So it's interesting. I've actually discovered a new food, which one of my favorite foods, oatmeal, which I think is on the low glycemic index. It's pretty.
Yeah.
I don't know. So maybe it is a PCOS thing, and I'm learning now here, which is great. But I actually contacted my endocrinologist a couple of months ago. I blame everything on breastfeeding because I'm still breastfeeding. So I'm like, oh, I can eat that because I'm still breastfeeding. That's fine. But I was eating oatmeal every morning for breakfast, but I found myself 30 minutes later, I was starving, no matter how much and then I found myself eating 3 breakfasts. Before noon came, I was eating 3 breakfasts. And I said, and I'm actually going back to check in with the doctor to see what's going on, because I'm like, is this normal? But I think she explained to me, and maybe you guys know, that it's the way my body is processed. Something's going on, but I am not processing it the way that maybe someone with PCOS, not with PCOS processes it, or not with insulin resistance. But it's one of those things, I eat it and it just triggers this cascade of needing to eat just more carbs and more carbs and more carbs.
That is so it's going into your system too fast, and you're getting a spike in your blood sugar.
Right.
Sometimes using, I by the way, I have a master's in nutrition, although I don't practice that anymore, but you can try a higher grain oat. If you're gluten-free, I can't do oat at all. So you need a protein and maybe a healthy fat at breakfast as opposed to a carbohydrate. What becomes really fun is when you're allergic to eggs. That's super fun. And, because even all the smoothies, the juice, the blah, 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 I would be like, I don't want to be ravenously hungry at 11 o'clock. Somebody is asking, what is your opinion, Dr. Daisley? And we do disclose that no one here is a nutritionist.
Yeah.
But what is your opinion on soy and PCOS and endometriosis?
So the thing with soy is that it tends to cause higher estrogen levels, particularly in the PCOS. Estrogen doesn't really play a big role. The estrogen tends to be quite normal. They tend to have lower progesterone levels, but so soy wouldn't really come into play there. In endometriosis, definitely because it is depending on that estrogen, I would stay away from the soy for endometriosis.
So I can say this, that if Dr. Right, he's probably going to come out of his case and say the same thing. I don't even know who the person is, so I'm not saying that. But if Dr. Vidali calls me after a case and he's like, oh my God, it was so hard, like the case was like connective tissue was just peeling apart. I could, you know, it was really like, it was like touching, you know, like sandpaper. I don't know, like what happened there. That's usually somebody, and then the person will wake up and he'll be like, what do you eat? I'm a vegetarian. So which is not to say that there aren't other reasons to be a vegetarian, the environment and health and heart health and whatever, but it's not so fabulous for your connective tissue. And then the other thing is, and Alexis said this, she was eating like this fantastic plant-based diet. Well, most plant-based diets are pretty high on the glycemic index. Alexis, did you have to go back to eating meat when you were really following the glycemic index?
So I didn't go back to eating meat. I was just not eating, you know, my chickpea pasta and sweet potatoes every day like I was. You know, I was eating that stuff like it was going out of business. Like that was just all I would eat. But I focused more on like the healthy fats and eggs too. I did actually avoid egg whites when I was like going through my treatment because I got really crazy with like the inflammatory stuff and like this and that. But yeah, I definitely tried to steer away from some of those and focus more on some of the proteins that I could. But it's hard as a vegetarian. I didn't go back to eating meat, although when I was pregnant, I ate turkey and weird things that I hadn't eaten in like 30 years. So, but otherwise, no.
We have a question about the keto diet and PCOS.
Yeah.
I'm going to let Dr. Daisley comment, but I'm also going to say, likely we will have CNY on, that is Dr. Kiltz, and he has his own book. And at the Endometriosis Reproductive Immunology Day, that's the second day of our virtual fertility weekend, Dr. Kiltz will be lecturing on preparing your body for fertility. And I know from speaking with some of our other speakers, he doesn't think you should be eating vegetables at all from a fertility standpoint when you're going through your cycles. But I'd love to hear, because that is not so great for our arteries, I'd love to hear Dr. Daisley's opinion on the keto diet.
Yeah, so actually, Babe, Barbados Associate of Endometriosis and PCOS, we held a medical conference, I think about 2 Sundays ago, a virtual one, of course, but we had a nutritionist come on and talk to us about diet and PCOS. One thing she did say, which I agree with, is keto diet can be fine in the short term because it does have those implications in terms of insulin not causing high insulin spikes. But one thing is it sustainable? I don't think it's sustainable to cut an entire food group out for the rest of your life. So that's my main implications in terms of the keto diet. The ketosis does help with insulin. 2, it does the ketones themselves help with satiety and preventing cravings. But my concern mainly is in terms of the longevity or the sustainability of the diet.
I found it really hard during COVID because you're not going to the grocery store every day. So making sure you order it was very hard. Like it's very easy to get a big thing of spinach and have that as your base for everything versus, and that could last all week versus then I need like a slice of turkey every 15 minutes. It was very hard. Yeah. I try. I try. So the other thing is, I read, Alexis has read the book, I think, but I read something in this book that we're going to be giving away for next week's Endo Summit Live. But the author who will be on with us, Amy Klein, said in this book, like, you do what you can do, right? You can't beat yourself up. And I think Alexis just alluded to that. Like, she tried during her cycles to do one thing, but she was going a little insane with it. So if someone says only eat organic chicken, don't eat regular chicken, and that works for you, that's okay. If somebody else, you know, if they say like, don't ever eat oatmeal unless you're out like hulling the oats yourself and hand grinding them, and that doesn't work for you, you have to be aware of that.
Yeah.
While also, I think embracing with PCOS, the glycemic index is going to impact you, and you can't out-medicate bad decisions in the kitchen. Like you can't have ice cream and then be like, but I'm on the metformin. And all right. So this is our, so this is actually, I was going to ask you this question before. What about these fasting diets and PCOS? What do we know about those?
So I'm assuming the person is talking about like intermittent fasting. Oh yeah, I can see the question here, right? So the intermittent fasting. So again, I guess that's like kind of a fad, but once again, it does tend to lower insulin levels because obviously you're not eating for a particular window. So you're not having any food at all to cause any change in your insulin levels. So it does help. I particularly like intermittent fasting personally. It worked for me. But as you said, there is highly individualized for the person. But the thing with these diets is that we don't have a lot of data on the long-term effects of them. They would help in the short term, but as clinicians, we need like data to really inform our decisions. And we don't have like very long-term data in terms of,
Right. So I got really bad colitis after one of my surgeries, and the general surgeon treating that said to me, I think you should try some fasting because it's empty, like for the most part, right? And here's what I can note, and also COVID ruined this for me too. But here's what I can notice is that after a while, once your brain is sort of trained that I stop eating at 9 and I start eating at 11 or 12 in the afternoon, you're not on the insulin roller coaster.
Yeah.
But if you do it on Monday, Tuesday, Wednesday, and then you cheat Thursday, Friday, Saturday, Sunday, you're on the insulin. You're not getting the effects of what the fasting is doing. So this question is talking about like giving the GI tract a break. While I'm not a doctor and I don't treat this and I don't have the data, I can say that is how they asked me to treat my own colitis, and it was pretty effective until COVID hit and I decided that I needed a snack at night. But I've been good the past 3 weeks, you know. I wanted Alexis, we're talking about a lot of like multiple ways of approaching something. We've talked about acupuncture, we've talked about physical therapy, we've talked about diet. Can you tell us, you work on something that helps people find that. Can you tell us a little bit, which to me I feel like is what you do is a little bit of making like good out of your whole experience. Do you want to tell everybody a little bit about what you do?
Yeah, absolutely. So I'm working with a company called Robin, and Robin is all about connecting aspiring, expecting, and new parents with integrative wellness resources and specialists. So whether you're trying to conceive, you're going through, you're trying to get on that path to parenthood, you're expecting, or you have just delivered and you're in the postpartum period, we can help you connect with specialists in each of those phases. So if you're looking for an acupuncturist during your IVF treatment, if you are looking for an infant sleep trainer and you're a new parent, we have a database of nearly 200 specialists in all different categories, I think up to 15 categories at this point. And it's just a really great resource, and it's in one place. So it gives people the opportunity to kind of explore in this very niche, area that we're all in. So yeah, it's great. And you can check out wearerobin.com. That's ROBYN. And yeah, I would love if you checked it out. It's a great resource. I wish it were around when I was going through everything. So I hope that people find it helpful.
Right. We did not, they are not sponsors, and we didn't know, but I thought while we were having such an integrative conversation, she and I, and we all have, I'm sure Dr. Daisley, her patients too, we've all been to clinics where they don't talk about, like it should be so hush hush that we should talk about seeing a nutritionist or talk about a yoga therapist or talk about, and so I think it's really important when we have those resources to share them with you. Doctor, so on the other side of things, if you are looking for an excision surgeon, the Endometriosis Summit does participate in what's called I Care Better, which is a catalog of excision surgeons, which you can, of course, find at endo.icarebetter.com. Dr. Daisley, what would be the lasting, first of all, tell them a little bit about your organization and how everybody can find you if they want to ask you questions.
Sure. So once again, because I do think we have some new persons. So the organization that I work with is called the Barbados Association of Endometriosis and Polycystic Ovarian Syndrome. It is a nonprofit or charity, and it was founded in 2016. I wasn't a founding member, but it was founded by ladies who were affected with endometriosis and really thought that sisterhood would help. It's really blossomed into a very, very active NGO within Barbados, where we advocate as well as educate persons on these conditions. Additionally, we also would advocate for other mental health disorders like fibroids as well. And we've also been trying to help in terms of policy change. Recently, we've been working on tampon tax, or the cost of sanitary products here in Barbados, as well as period poverty, which is an international issue. Yeah. So if you want to find us, if you want to find us, once again, our Instagram is at Endo and PCOS BB. You can reach me personally at Rashida.Daisley at endoandpcosbb.com.
Awesome. Okay, now our hour is up. We are a smidgen over, but what I'm going to do, if our guests want to step off, because I don't want to take up any more of your time, I do want to say that Dr. Daisley will be present running our PCOS breakout room at the Reproductive Immunology Conference on October 25th. And Alexis will be probably mulling around the crowd there, and we are around, and tickets are on sale at theendometriosissummit.com. And you do not have to have endometriosis. This is a conference for all fertility concerns, and we hope you'll go and join. I'm going to take a stab at some of the questions that are in the Q&A. If our guests want to wave goodbye, that's fine. I hate to, but I feel like I don't want to leave so many questions. Whatever I can't answer, I'm going to have Dr. Vidali do in his Insta stories tomorrow. So I'm going to take a shot at those questions. If you guys have to go, you can just pop off. Otherwise, you can stay and give it a shot. So our first question, and it's up to you guys, like totally, usually I don't do this, we get it in the hour, but I feel bad because we didn't get to any of these because they weren't topic specific, and also I was missing Vidali. So all right, so is endometriosis a factor for embryos not taking during transfer? Absolutely. We know that endometriosis creates an inflammatory response, and while endometriosis is not a uterine disease, it does create an inflammatory response within the uterus itself. And lots of discussion on that will go on in the Reproductive Immunology Conference, but absolutely endometriosis is a factor for embryos not taken. I believe, if you just listen to Alexis's story, that having that silent endometriosis and having it treated made a huge difference in implantation being successful. By the way, I have this whole thing, I hate the term implantation failure. I guess that's that pediatric therapist in me. I want to be like, implantation, I want to name it something else. I hate the word failure. I don't want anybody to feel like they're a failure. Like a modified implantation, I don't know what to call it. But endometriosis creates an inflammatory response. You will also learn at the Reproductive Immunology Summit that the presence of endometriosis itself actually has this amount of cells that affect implantation. And I'm going to leave it at that because you guys should really buy tickets. So the next question is, they have an endometrioma, and that you've had recurrent miscarriages and now unexplained infertility. So if you have an endometrioma, it's not unexplained infertility. It's explained infertility, but endometriosis is a huge cause of that. And if somebody's telling you that your miscarriages are normal, they are not normal. And we want to do everything that we can to minimize the grief and the trauma associated with miscarriage and really treat your endometriosis the right way. And I don't believe that you have to use the highest level excision specialist that you can get to, which is why we're such big supporters of the I Care Better system, because those are video vetted excision specialists. And having an endometrioma, you should also know that whether it's antiphospholipids or immunotherapies, there may be something that needs to be modulated with your endometriosis in addition to having a complete excision in order for you to give live birth. And actually that's the keynote, which will be given by Dr. Vidali on October 25th. I'll also say that you can reach out to Dr. Vidali, and I think he does consultations on that exact topic. So like, don't quote me, like don't call him up and say Sallie says, but years ago, it used to be free. I don't know if his consult is still free anymore. Some of these we always ask, don't ask specific questions about yourself. So I'm giving it a shot tonight. I have to say that gestins don't really do anything but treat the symptoms of endometriosis. They're not like a boost to your fertility. They're not likely shrinking the disease. They're not modulating the disease in any way. And if you're in excruciating pain, it could be because the disease was not properly managed. And I would encourage you, true endometriosis, while it may reoccur, it shouldn't be like growing back because it's taken out at its root rather than being shaved off at the top. That's its own life. But I would say that we're not typically a family that believes in using gestins instead of good quality excision surgery. So in terms of the cortisol, progesterone, and DHEA question, I am going to have Dr. Vidali answer that on Instagram because I know the answer, but I'm totally going to butcher it, and you deserve better than that. Usually we're much more, you should see when we go to Facebook, we could be doing this for hours. So we talked about hysterectomy. I do believe so. While you guys are sticking around, which you did not have to do, Dr. Daisley, do you think metformin is the best medication for insulin resistance, or are there newer medicines on the market?
To my knowledge, metformin is the only one that we have the data on that really can treat PCOS insulin resistance.
Right, so I've had this conversation with my doctor, and the answer is the same. Sometimes I see patients now and they wear the sensors, right? So they can really tell like 8 cracker going up, right? But they still need the metformin in the background. Yeah. And I've never seen anything else prescribed for PCOS insulin resistant than metformin. The other thing is metformin is available generically, and it's oftentimes the most cost effective and most data presented pharmaceutical. Some people try the Inositol for a long time and just need the rest. So how can I convince a doctor to do an excision? Really? So I have to get out my soapbox for a minute, but excision is a technique with endometriosis that's super hard. You can see that Dr. Vidali is still in the OR at 9:43 at night, because when he got in to go to the first case, it went over about 3 hours because he went in there and you have to get every little bit of endometriosis as we have a doctor on our faculty from Massachusetts, and he likes Kip McKenzie, and he likes to say, I excised it every stinking bit, right? So it's not something that you can learn because a patient asked you, and I know like we've had other lives where the patient has said, I asked my doctor to do excision, so I'm assuming they did it. If they are not specifically trained in excision, then doing like excising one lesion and leaving the rest of the pelvis a mess, or worse, burning it, isn't excision. And you do really need to go to a vetted source and choose a doctor in your area. You can't convince a doctor to do an excision. It's like, I don't want to convince my doctor who's never done hip surgery to do a total hip replacement. I want to go to the person that knows how to do the total hip replacement. So you have to use somebody that is doing excision all day, every day. I encourage sources like I Care Better or Nancy's Nook over just doing a Google search, because on a Google search, we know that anybody can use the word excision for now until I Care Better takes over the world, but not everybody really knows what they're doing. So and we have this in New Jersey, we have 2 doctors that market excision, and they're maybe cutting one thing out and buzzing the rest. So that's my soapbox on that. I'm sorry that excision is so hard to access. I have done everything with my career to make it easier for you all to access, including myself, and we're working on it. But change doesn't happen overnight. And I also haven't seen ACOG, which you don't have that in Barbados, but I haven't seen ACOG decide that they could change the standard of care for endometriosis to excision. So until that happens, you know, it's going to be a little challenging to get excision surgery for endometriosis. We're working on it. Okay. I'm going to assume, can you excise the endometrium is a typo, because endometrium is the lining of the uterus, whereas endometriosis has absolutely nothing to do with the lining of the uterus, and it's tissue found outside of the uterus, and it's not even related to the inside of your uterus at all. And we're rounding, we got a lot of these. Is there any connection between adult onset allergies and PCOS?
I'm not sure about that one.
I would say that oftentimes if your inflammatory markers are off the charts, then you're going to develop high histamine related allergies. Somebody wants to talk about insurances and excision. And I have to say, sometimes excision does come out of pocket and it sucks. And I'll probably never own a home because of the burden of my care was on my financial life. And then of course we had a pandemic, and now I'm not working as much. So it's a big issue. I believe that in the future, there will be people who try to, make some changes within the insurance companies, but until the ACOG standard of care changes, an insurance company has no reason to make any changes in terms of their excision surgery care. Now, those of you seeking fertility benefits, we don't usually talk about that, but if you are seeking fertility benefits, I do refer you to something called progeny. Progeny is something that you can work with employers. You can ask your employer to cover through their doctors. You can go and look that up. I am not a fan. I'm not going to spend hours. These are their own lives. I don't believe letrozole and norethindrone are doing anything for endometriosis. They're actually, if you look at the studies, they're not doing anything beyond what regular birth control is doing. It's just modulating the symptoms. It's not doing anything for the lesion of endometriosis, and it's not doing anything for the inflammatory onset and insults of endometriosis. So if you're looking for fertility, I can tell you that neither of those drugs are helping your fertility in any way whatsoever, because they're not attending to your immunological profile and they're not attending to your disease. Is surgery the best option? It depends where you are in the fertility process and if that makes sense for you. Dr. Gargiulo, who's been on with us quite often, Also, a fertility specialist will say sometimes it's very important to get your eggs out before you go through surgery, and sometimes it isn't. And what I would say is it's very important if you're looking to extend your fertility or to deal with fertility to see someone who really, really understands endometriosis and fertility. In Alexis's case, that happened to be Dr. Vidali. I'm not going to touch the Orlissa question. I have to say, Orlissa does not attend to the actual lesion of endometriosis. And even if you look in the footnotes of their study, Orlissa didn't do anything more than birth control did. And you run the risk of your hormone levels not returning to where they need to be even 6 months after you've stopped taking it, which, like Lupron, people complain of these issues 20 years after taking the drug. So we're going to leave Orlissa there. You can look at our Endometriosis Summit video channel, and there's a discussion from Dr. Arrington from the Center for Endometriosis Care, where he talks a little bit about, you know, his feelings on Orlissa, which are my feelings on Orlissa. If you have long endometriosis, I sincerely encourage you to have that excised. I know Dr. Vidali does it. I know Dr. Cernovo does it in Center for Endometriosis Care in Atlanta. I believe that Dr. DeLumba does it in Texas. And I also believe, but I'm not 100% sure, that Dr. Mossbrooker does it in the Pacific Northwest. And that is all our questions. That's the first time I've ever done that. Yes, somebody must be from abroad. They're talking about Elagolix, not Elagolix, not a fan, because again, it's not attending to the disease itself. It's modulating symptoms. And actually, if you look at the studies, it doesn't modulate symptoms really any better than birth control is, except it's more expensive and has more side effects than that. Yeah, so those are all my questions. And I will remind you, wow, you guys really hung in there. I will remind you, next week we will have Amy Klein on from the Trying Game. We're going to announce a giveaway on our Fertility Facts Friday, where we will give away this actual copy. And more importantly, I will go to a post office because I barely leave the house. So this will be a very exciting thing. That'll only make me hysterical for a long time. And we are doing it instead of Tuesday night because the debate is on Tuesday night and I need to scream in front of the television for a little while. We will be with you on Wednesday, September 30th at 8:30 p.m. And it should be less of me just answering questions because it'll be back to our regular format. I want to thank Dr. Daisley so much for being here. I want to thank Alexis for being here. Guys, this is the first time Alexis has really shared her story publicly. So let's give a lot of claps.
Oh,
you know,
thank you.
Yeah, and lots of claps coming at us from Barbados.
Thank you so much.
Awesome. Yes, and so somebody is asking what happens to these videos. You can see on theendometriosissummit.com, not only are our tickets on sale for virtual fertility weekend, but also there sits a page called the video library, and all of our content is there. You can also find us on YouTube, but if you don't want to, that's under the Endometriosis Summit. But it sits on our website on the video channel. You can hear Dr. Arrington's opinion on Orlissa. I think that's what I asked about, but there's lots of videos there. Somebody is saying they jumped on late, but they're getting very excited for the conference. I am so excited. And it'll be a journey because really this is the first time we'll be virtual. The first day will be on Zoom. The second day is being run like a little differently. So we'll have to see. It's not Zoom. We'll have to see how that goes. All right. Thank you, everybody.
Thank you for having me.
Thank you for having us. Thank you so much once again.
All right. Awesome. Take care.
Bye.
Bye.
Bye.